My name's Merrin Hicks. I'm an emergency and critical care specialist here at Animal Referral Hospital. I've been working in emergency for about 17 years now, so quite a long time. And what I wanted to do tonight was just share 10 quick tips and tricks for general practitioners out there. Just little things, recent updates and things that I guess I do differently than what I did 5 years ago. And I hope you'll enjoy the presentation. So this is Darcy. He is an 8-year-old male castrated domestic medium here who had a 48-hour history of lethargy and breathing troubles. And you can see from the way he's breathing in the image that there's quite a lot of abdominal effort. What I guess we're all taught at vet school and what the inclination is to go and quickly take a chest radiograph with minimal stress. But what we actually find in these guys is even the quickest x-ray can be stressful. So one thing that I've started doing differently in the last couple of years is actually running a feline cardiac pro-BNP. So pro-BNP is a cardiac enzyme that's released when the atria is stretched or stressed. And basically, in cats with respiratory distress, there's a relatively high sensitivity and specificity for an abnormal feline pro-BNP to actually detect cardiac disease as the cause of the respiratory signs. So you'll see on the slide here a normal result. So a normal feline pro-BNP is that the sample spot is lighter than the reference spot. An abnormal result, the sample spot can either be the same colour or darker than the reference or the positive control. And if we had a reference laboratory right next door and we're able to get the number straight away, that would be helpful. But what we do know from the manufacturers, and this is straight from the IDEXX website, is that a normal pro-BNP correlates with a pro-BNP quantitative value of less than 150 picomoles per litre, which is very low, very unlikely to have cardiac disease. In an abnormal result, that'll be greater than 150 to 200, and you should go ahead and investigate that animal for cardiac disease through normal channels, be it an echocardiogram, chest radiographs, or emergency treatment until you can get those procedures done. The second thing that I would then do with this patient before proceeding to radiology is actually measure his LA to AO ratio. So with the cat in lateral recumbency, in right lateral, and actually fanning through the 6 specific cardiac views, we get to this classic LA to AO ratio view in the right parasternal axis view that we can measure the size of the left atrium to the size of the aortic outflow tract. And the aortic outflow tract is that classic Mercedes-Benz sign that we're taught in vet school. Normal LA to AO ratio should be less than 1.5. So if the left atrium is more than 1.6 times the diameter of the aortic outflow tract, that cat is very likely to have left atrial enlargement and very likely to have cardiac disease. And in people, the bedside combination of ultrasound and cardiac enzymes together obviously increases the sensitivity and specificity of that test. The third thing that I wanted to update you all on is something that I've suspected for many years, is that chest radiographs in cats are really hard, particularly when they're in respiratory distress. But a recent paper out of Italy actually reviewed a couple of hundred cats in respiratory distress correlated that with the echocardiograph findings and found that the radiographic appearance of congestive heart failure in cats is actually highly variable. So the first thing was that pulmonary edema can look like almost anything in cats. So it can be focal, it can be diffuse, it can be symmetrical, it can be non-symmetrical. The second thing is that thoracic radiographs were relatively insensitive at detecting mild cardiomegaly. And the third thing is that the classic things that we're all taught, things like assessing the size of the pulmonary veins, enlarged pulmonary veins may not actually be present. The fourth thing that I'd add to that do make radiographs in cats with respiratory distress difficult is a fair proportion of cats with congestive heart failure actually have a pleural effusion. So when we take a chest radiograph, we just see a complete whiteout in a lot of cases, or at least obscuring the cardiac silhouette and vessels such that we really can't measure those things. And again, that's where coming back to our cage side ultrasound, obviously being able to measure the LA to AO ratio is fantastic and probably a slightly more advanced step. The basics of cage-side ultrasound are abdominal free fluid detection, pleural fluid detection, and pericardial effusion. So I would encourage anyone with an ultrasound machine in their practice to get really good at abdominal free fluid, so you can start just by imaging the bladder. Best place to see abdominal free fluid is actually just cranial to the bladder. Then perform a full 4-quadrant assessment, then get good at looking at pleural and pericardial effusions. So update number 3 is the radiographic signs of congestive heart failure in cats are highly variable. The next update that I wanted to share with you is that I believe that Pimabendin is useful in cats with congestive heart failure. Now, this is an off-label use. It is not registered for use in cats. I'm merely presenting research findings here. But the main contraindication to the use of Pimabendin in cats is left ventricular outflow obstruction. If they don't have left ventricular outflow obstruction on an echo, then it's a reasonable thing to consider. Now, this is based on a couple of fairly large retrospective studies, and it doesn't intuitively make sense because cats don't have systolic dysfunction. So why does Pimabendin help, say, a cat with hypertrophic cardiomyopathy? The answer is no one really knows. But one study did show a median survival time of around 600 days with Pimabendin compared to 100 days without. And this is for cats in congestive heart failure. A couple of theories as to why this might be happening is that being a phosphodiesterase 3 inhibitor, does the Pimabendin actually promote ventricular relaxation? Does it promote atrial emptying? There's also some evidence from the human side that Pimabendin has an antiplatelet effect. So it may be a combination of these things. And I think that this is something that is potentially going to be exciting that we're going to hear more about in the future. Okay, we're going to change track a little bit. And the 5th tip and trick that I wanted to share with you is the utility of CPAP in dogs with congestive heart failure. So for many years, I've struggled with those really severe congestive heart failure dogs, or cats for that matter, that you've tried everything, you've given diuretics, they're on high rates of nasal oxygen or in an oxygen chamber. They might even be on something like sodium nitroprusside, intravenous Pimabendin. What do we do with those cases that just aren't responding? And I think something that I have started to do in the last couple of years is be a lot more comfortable, a lot more confident and proactive in offering ventilation to those pet owners when you're at that point where you might feel that you're heading towards euthanasia or pet's persistently hypoxemic, excessive respiratory effort. And CPAP is basically a mode of ventilation. It's considered a minimally invasive mode. So instead of completely emptying the lungs at the end of each breath, basically what CPAP does is it provides continuous positive airway pressure. So the alveoli are staying a little bit open at the end of each breath. Now, that's obviously going to promote gaseous exchange, but CPAP has benefits far beyond just the gas exchange side of things. I'll talk about that in a minute. You're able to sedate the pet, reduce oxygen demands, obtain an airway, provide 100% oxygen. There was a study published a couple of years back now, and it's only 16 cases, but this was in JVEX. It was the outcome of positive pressure ventilation on dogs and cats in congestive heart failure. And these guys actually needed fairly short times on the ventilator. I think it was around about less than a day, so around about 20 hours was the median time on the ventilator. And around 80% of these animals went home. So it's not something that's necessarily going to cost the clients $15,000 and they're in ICU for a couple of weeks. I think getting in early, being proactive, getting them on a ventilator for 12 to 24 hours before they decompensate can actually save a large number of these cases that might otherwise die. There's also some really interesting stuff coming out, new modalities of providing CPAP in dogs, things like the CPAP hoods and high-flow nasal oxygen, which is a Fisher and Paykel device that sits just under the nose and provides consistent high-flow humidified oxygen up around 1 litre per kilo per minute. The thing that is cool about CPAP, as I mentioned before, is it provides benefits just beyond just the respiratory side of things. So we all know that there are some downsides to the cardiovascular system when we put a pet on a ventilator. So decreased venous return is the one that springs to mind. But PEEP's been shown to reduce overall oxygen demand. It's been shown to improve myocardial oxygenation, so oxygenation to the heart muscle itself. It reduces afterload in the failing heart, and it also reduces a phenomenon called hypoxic pulmonary vasoconstriction in cases of severe hypoxemia. So that little diagram is just there to remind us that the heart and the lungs are all one unit. I just wanted to talk briefly about Mimi, who's a 4-year-old female spayed Cavalier. She presented to us with an acute onset of vomiting. She'd actually been unwell for around about a week. Mimi had collapsed at home, and when she presented to us, she had a heart rate of around 200. She had cool peripheries. She had a brisk refill. Her gums were also very dry, and respiratory rate of 80 breaths a minute. We went on to get some additional baseline parameters just to help assess, I guess, where she was at. Her mean arterial pressure was 60 and her lactate was 4.8, with the normal being 0 to 2, so quite a high lactate. So what I wanted to ask the audience is Mimi in shock? What things on that list make us worry that Mimi might actually be in shock? And I think we can all confidently say, yes, she is in shock. So perfusion parameters, the brisk refill, the rapid heart rate, the cool extremities, slightly low body temperature, and the slightly more objective data is she's also hypotensive and hyperlactotemic. So it's important, I think, with any really critical pet to think about all the factors that influence oxygen delivery to the tissues. So when I'm asking students and junior vets what is shock, I think the best one-word answer is decreased oxygen delivery to the tissues, or DO2. And that's a balance or combination of, product of, total arterial oxygen content, so hemoglobin times the PaO2, multiplied by the cardiac output. And the range of factors that come into cardiac output are how forceful are the contractions, so contractility, preload, afterload, stroke volume, obviously. When it comes to shock, not all shock is the same. So the broad categories that I find useful clinically are to try and differentiate hypovolemic from cardiogenic, from obstructive shock, from distributive shock, because they all have slightly different treatments. As you can see from this slide here, hypovolemic shock, we obviously need fluids. Cardiogenic shock, we obviously need to make the heart pump more efficiently, so we need to use things like inotropes. Distributive shock, so the classic septic shock, the patient is actually significantly vasodilated. So they get to a point where they don't actually need improved vasomotor tone, and that's where vasopressors come in. So Mimi came into the ICU, we got her blood pressure, we got her lactate. As we said before, we were very quick to pop an ultrasound on her belly. And you can see from this image up here, she actually had a fair volume of free abdominal fluid. That's an image just around one of the liver lobes. She actually had positive free fluid in all 4 quadrants. We took a sample of that and we found a large number of intracellular bacteria. Total protein of that fluid was 44 grams per litre, so that was consistent with a septic exudate. And in the meantime, we also ran a CBC in-house and found that she had a really high white cell count of around 26,000. So the next question I have for everyone, okay, we've already decided Mimi's in shock. Does Mimi have sepsis? What is sepsis? So sepsis is a dysregulated host response to an infection. So the way I think about it is sepsis is a syndrome where the infection that should be localized, let's say a pancreatic abscess, becomes generalized, and those generalized inflammatory processes actually work against the organs and may lead to things like multiple organ failure. So if we look at the original definitions of sepsis in dogs and cats, and these are still the definitions we use today, nearly 20 years later. I know this is supposed to be the latest and greatest, but sometimes in ECC, going back to the fundamentals and the basics is really, really important. So presence of 2 of 4 or 3 of 4 of these in a cat with known or suspected infections. So either a high or low temperature, bradycardia or tachycardia, tachypnea, so greater than 40 breaths a minute in cats, greater than 20 breaths a minute in dogs, and either a high or low white blood cell count. So if we look back at Mimi, Mimi certainly meets actually 4 of those sepsis criteria. So if we go back here, she's tachycardic, she's hypothermic, she's tachypnic, and we know her white cell count's 26,000. We've also confirmed an infection because we now know she's got a septic abdomen. Mimi's in shock. Mimi has sepsis. So just to recap, she has sepsis and septic peritonitis. She's had 30 mils per kilo of crystalloids when she first arrived. We'd also started antibiotics, but her mean arterial pressure remained low at 55 millimetres of mercury, despite what I considered to be a fairly good fluid resuscitation, so 2 boluses of 15 mils per kilo. So what do we do with Mimi now? Well, we repeated a 15 mil per kilo bolus, whether or not that was needed. That was bolus number 3, so she's had a half of a blood volume. But her mean arterial pressure still stay below our target of 65 millimetres of mercury. So I'm not sure what everyone else would do out in general practice, but she's at the point where more fluids aren't going to help. We need to think about a vasomotor tone. So we popped her on a vasopressor and got her into theatre. Does Mimi have septic shock? This is before surgery, obviously. So septic shock is defined as hypotension despite adequate fluid resuscitation in a patient with sepsis. So yes, she had all of those things. She has sepsis, we know that. She remained hypotensive despite adequate fluid resuscitation, possibly a little bit too much fluid, and she has septic shock. Despite that, we felt once we started the presses, she was as stable as we could get her, and we needed to look at source control. We took her to theatre when her MAP was around 75 millimetres of mercury. She'd had 45 mils per kilo of crystalloid. She was on a noradrenaline CRI. And diagnosis for Mimi was that she actually had a perforated gastrointestinal foreign body. There was a gum nut floating around in a soupy mess. And she actually did really well. And spent 10 days in the ICU, took a long time to start eating, had a feeding tube, etc. But I think it's a good example of understanding the difference between sepsis, septic shock, and obviously septic peritonitis is a little bit easier to conceptualise. One of the newer updates or definitions coming out in people is what we now call Sepsis 3. And it's a massive big paper published in JAMA in 2016. But one take-home message that I really like from Sepsis 3 is, as I mentioned before, sepsis is a life-threatening organ dysfunction that results from a dysregulated host response to infection. And the way that sepsis evolves in people and the genetic input, whether one person is more predisposed to sepsis than another genetically, is really fascinating. And they also publish a lot of these big human, they have a little section in lay terms, which I always really like. Sepsis is a life-threatening condition that arises when a body's response to an infection injures its own organs or tissues. And that's one of my big take-home points from the seminar tonight, is that if you can recognise sepsis in your patient, you will be able to save their life. They are much more likely to die than your general hospital population. They need aggressive care. They may need vasopressors. They need constant blood pressure monitoring. The owners were really happy with the outcome for Mimi. So update number 8 is use vasopressors early. And I just remind you of this slide here, in that hypovolemic, cardiogenic and distributive shock all have completely different etiologies and completely different treatments. Update number 9 is that antithrombotics are in. These are the new cool things. Plavix and Clexane are 2 drugs that I have started using a lot in the last couple of years. Plavix or clopidogrel is an antiplatelet drug or a platelet inhibitor, and we all know from the fat cat studies that we should have all of our cats in congestive heart failure going home on Plavix. But the other thing to think about is the indications for use for anticoagulants. So I use the example of enoxaparin or Clexane, which is a low molecular weight heparin, a little bit more predictable and maybe a little bit safer than, say, something like unfractionated heparin. And the curative guidelines are an example of such a consensus statement, and basically looking at the evidence for antithrombotics in dogs and cats. We should be using antithrombotics in all dogs with IMHA or protein-losing nephropathy, something like enoxaparin or low molecular weight heparin. We should be using enoxaparin in sepsis in dogs if another risk factor is present, and the paper identified risk factors to include pancreatitis, use of corticosteroids, heart disease, cancer or hyper A. And we should be using Plavix in cats with cardiomyopathy. The final update I have for you is a drug that I've really only started using in the last couple of years called tranexamic acid. And tranexamic acid, along with aminocaproic acid, is an antifibrinolytic. So in situations where we think there's excessive hyperfibrinolysis, this may be beneficial. In people, it's used in things like excessive postpartum bleeding, excessive bleeding in a total hip replacement or a total knee replacement. And certainly the one interesting thing that a lot of GPs out there might be able to relate to is the excessive bleeding that we see with greyhounds. And some work out of the Ohio State University has started to describe this more as a hyperfibrinolytic syndrome. So I use tranexamic acid in my heme abdomens. We do use it sometimes in surgery, and we do certainly use it in greyhounds that might be in for something like an amputation. Just in summary, cardiac pro-BNP and a quick thoracic ultrasound before chest x-rays is really great for a dyspneic cat. Be 100% comfortable with abdominal free fluid detection from the day you graduate. Recognising sepsis will save your patients. Be familiar with all the consensus guidelines that are out there. You only need to summarise the main points. It's usually just a couple of big chunky take-home messages. And the one thing I didn't talk about today, but always like to fit into my talk, is communicating effectively with your clients is essential in any emergency situation. I actually consider that to be the key to any good ECC practice. Hope you enjoyed it, and look forward to seeing you all soon.